Okay, thank you for all the speakers. And our next session will be moderated by Dr. Sabel Carr.
So we've come to the second last session of the day, and I have the privilege of introducing Dr. Andrea Natale, who is perhaps one of the most prolific radiofrequency ablator for atrial fibrillation. He has one of the largest experiences in the world, and he's going to speak on LAA ligation and occlusion technology in the Incubator. So he's going to talk about all different devices in this field.
Thank you. So let's try to do this quickly. I'm going to show some of this, some sort of. Can you click? Okay. Well, certainly, I think you all got this message. One of the reason why we're all here talking about this problem is because stroke associated with atrial fibrillation is not just a sort of a dismal, simple problem, but really affect people in a major way, and has a 70% chances of death or permanent disability. So it's something that really impact on people. Sort of ability to function and maybe even to survive in many cases. You know, it's, most of the stroke related to atrial fibrillation are sort of end-of-life event for many of these patients. You heard that why the appendage is important. Data suggests that it is probably, at least in patients that no other sort of cardiovascular issue like major aortic plaque is probably one of the most relevant causes of a thromboembolic event. And you also heard that, which is relevant to the device, we'll get there, that the appendage is a sort of a structure with a variable morphology. Certainly, you heard people like before a comment with an opening, it is not circular. There is a different thickness, and so. Why bother though? You know, if we have drugs that has been proven effective, this is data from all the Coumadin trial showing a significant reduction in thromboembolic events and mortality in patients treated with warfarin as compared to placebo or aspirin. The problem is that, and this is something that I think for those of you involved in clinical practice, the problem is that patients do not like to take drugs. And in fact, when you look at even study where patients were encouraged and follow up very carefully, there is a very high discontinuation rate of warfarin. There are a lot of data showing that warfarin is underused in patients that should be taking warfarin. And after all, although these drugs, both warfarin and some of the newer medication protect patients from their thromboembolic risk, they come with other side effects, risk of bleeding and other complications. And even with the newer drug, which supposedly, should sort of increase the compliance because they don't require specific diet restraint, they don't require ongoing blood testing. Even with the newer medication, the rate of discontinuation because of side effect or because patients they just decide not to take it is not insignificant over time. And those are data coming from the trial where there is clearly a much more controlled environment to encourage patients to continue to take the drugs. So in clinical practice, those numbers are much, much higher. And I think we all have seen, for example, with the Ligation, I would say that in my practice, probably a good third of the patients stop the drugs for GI side effect. And then if you follow this patient over time, this number goes up because of other issues. So certainly there are more options to treat pharmacologically patient at increased risk of stroke, but these come with other issue, and there is certainly a compliance problem, either perceived or real, that sort of make these drugs less appealing to our patient over time. So this is where sort of endovascular device, either endocardial or epicardial, sort of come into place in managing this patient. Now, although this is not the case in US, already in the European guidelines, a mechanical closure of the left atrial appendage is something that is considered a class 2B indication for patients that are not candidate for anticoagulation, or that they have sort of experience complication with anticoagulation therapy. So I think this is something that hopefully it will happen soon, even in US. The PREVAIL study will be presented at the late breaking trial, the American Heart Association meeting in a couple of weeks, so very soon. But already data from the PROTECT AF suggests that this is not only an effective alternative to Coumadin, but it could be even a more cost-effective, if you look at this data, especially when you look at the cost of some of the newer anticoagulants. So we're looking at something that potentially can be as effective, if not better, if you look at the on-treatment patient, but it can actually be even economically more effective than some of the newer anticoagulant medication. So let's look specifically at the device. I want to re-mention, although you heard this, about some of the issue that we have with the existing device, because some of the new technology or some of the newer version of the existing device, they really try to address some of the issue that we have seen with the current version of the device being used. So as you heard, there are epicardial and endocardial option. You know that this is probably the only proof of concept that we have, and probably in a couple of weeks we'll have more data to support this approach. This is one of our patients. This is actually the optimal outcome. You put the device, you check a follow-up, and everything is closed. Unfortunately, it doesn't happen the way you heard this morning about data from the PROTECT AF. Can you click? It doesn't. Data from the. Can you click? Move forward.
Next slide.
Next slide. Okay, data from the PROTECT AF. Next one. Showing a significant number of patients above 20% with some degree of leaking. Now, in this study, the presence of leaking, both severe or minor, did not seem to affect the impact of risk of stroke. In fact, can you click forward, please? Can you go forward? Yeah, click. Did not appear to sort of affect the outcome of this patient. However, this might not be sort of the rule. This is actually our own experience, showing also about a 25% rate of leaking. But in this series, there is one patient. What we did, we follow probably, we repeat more intensively than the standard protocol, and we saw that when the leak tend to get bigger, actually, it can lead to a stroke. In fact, the only patient with a leak that had a thromboembolic event showed this leaking area actually, instead of remaining stable or getting smaller, actually got a little bigger, and that patient eventually went to a surgical amputation of the appendage. And the funny thing is that leak that we clearly saw at TE getting bigger, in surgery, we could not see it, which was kind of interesting. There was
You couldn't see it during the procedure?
We could not see with the open heart when we went to surgery to actually remove the appendage. It was kind of interesting. Although it was very obvious that by TE, not only was there, but it got bigger over time. But when the patient was in bypass and they opened the heart, it looks like the appendage was closed. It was kind of interesting. Now, the other things, can you go back, please? The other things that we actually learned, and this is something that you also heard before, is that in some patients, this clot right in the middle of the device, right where the hook of the device is placed, can form even 6 months after the implant. This actually was a random TE that the cardiology did in this patient, although the device was in place already for a year, and it has been proven to actually have occluded the appendage appropriately. He did the TE anyway, and he found this large clot sitting in the middle of the device. So
This was over a year ago.
over here, yeah, this is a year TE. So so the issue with this system are incomplete closure, thrombus formation of follow-up, and the timing of that thrombus formation is not necessarily close to the implant, as I showed in our case. And then obviously the inability to retrieve suboptimal deployment takes place. So this is a sort of the attempt to answer some of these questions. The fourth generation, and now there is a fifth generation of the Watchman. They really try to bring this the hook not to stick out. Hopefully, that will sort of reduce the chances of the sort of central late thrombus formation. Also, the newer device is going to have more radial force, so the chances of this appendage leak will be reduced. There is already some data coming out of Europe, and there is also device design that will allow in the future to make this device hopefully retrievable. The Occlutex device, beyond sort of trying to address the same issue of a sort of safer anchoring system instead of having this barb as this sort of loop for fixation, but also use material that hopefully is going to be less thrombogenic and so less likely to perforate because of the anchoring system is different. Instead of the barb has these loops. The material hopefully will favor industrialization, and so will reduce the chance of this thrombus formation that we've seen, and hopefully will be a more flexible device. But those are attempts to answer some of the issues that we've seen that have to be sort of proven in real life, and right now there are very limited data with this newer system. It's one of the systems being placed in an animal. The Coirex is also, so one of the things that you have seen in the past, yesterday and today, is that both the cardiac plug, especially the newer version, the Amplatzer, sorry, and especially the newer version, and the Watchman need to be deployed at the tip of the appendage before they spring out. The Coirex actually has one of the potential advantages that doesn't have to be deployed at the tip of the appendage, so there potentially could be less chances of perforation by doing so. And also the material that you use in this device potentially is less thrombogenic, so there is less chances of that sort of central thrombus that I showed you before on the Watchman device. Oops, sorry. So this is another view of the Coirex as a retrievable anchor, although the initial experience with this device was actually stopped because of a higher rate of dislodgement. Now the device has been redesigned, and the clinical experience with newer device, it's sort of just at the early stage, so we'll see. But the earlier version of the device actually had a very high rate of dislodgement, and actually the initial clinical experience in New Zealand and Europe was terminated because of this issue. So so this is a sort of an idea at this point, the potential use of material that actually sort of conform to the shape. So you place it inside the appendage and just conform to the appendage shape, no matter what it is, and then eventually is sort of absorbed, is a bioabsorbable material. This is something that has not really been tested in humans. So, but is an interesting idea that I think potentially can become an easy solution because it doesn't have to stretch the device, something that really conforms. We've seen some of this in catheter ablation device that they never made it to the market, and this is sort of the use of this self-adjustable, self-shapeable material has been now sort of applied to the appendage closure device. So this is something to look forward to. Now let's go to the epicardial device. Here too there is a sort of an array of system. I cannot tell you that this is an area where there is a lot of interest. Some of these are surgical device. You heard about this. You heard about the cardioblade that was sort of terminated because of the inability to enroll. But this is a concept that fortunately continues to be explored by the surgeon because it's something that I think need to provide more data. This is the lariat, and I want to spend a few words because to be fair, and I think this is something that where some of the registry that you heard Dr. Lee are sort of being started are going to be very valuable because to be honest, the early report from the single center study in Poland, I think many of the issues that we are learning about were underreported, and I'll mention some of them. So this is a sort of the ideal deployment where you see at the end a complete occlusion. But now we have, at least we have seen two patients like this. This is a patient that has a complete ideal acute outcome, and we usually keep this patient on Coumadin or anticoagulation for a month, and then at 1 month you do a TE, and at that point, if the result is optimal, we stop. So one issue that we have seen is that if you don't do that, you're going to see a bunch of patients coming up at their 1 month TE with a big blob at the center of the appendage in the area where probably there is more inflammation and necrosis. So the idea that by using this device you can stop the blood thinner right away, I don't think it's a reality. I think we need to be worried about, and actually we should probably treat this patient with a blood thinner at least for a month, and then at 1 month, if everything looks good, then at that point you can stop. But this is a patient where at 1 month, despite an optimal acute results, there is an opening, a significant opening in the appendage. You can see this is another view of the same patient. This is the 2D, and this is sorry. Oops. Can you go back? Okay, this is a second patient that actually, interestingly, was done about a week after that has the same issue. And I think talking to other people that are involved, there are others that have seen this problem. This is clearly something that has to be addressed in the manufacture of the system, because all these cases have an acute optimal results, and they show reopening at the follow-up TE. So incomplete closure or reopening are certainly issues that need to be addressed. Thromboformation is still a problem. Another probably issue with this epicardial approach is the need for more expertise. You need to be comfortable with epicardial access. In our center, actually, we had no complication because of the epicardial access, but we've seen, reopening. We've seen central thromboformation if the patient were taken off Coumadin right away. Another issue that was certainly underreported, you've seen before from the single center European study, only 1% of late effusion. This is actually much more common, and it's clearly not a access issue. It's due to the fact that you have a piece of tissue that is necrotizing, because most of the time these late effusion are actually clear. They're not sanguineous fluid, but it's serous fluid. So clearly something that comes from the irritation, and it's much more than 1%. We actually usually keep the drainage for 2-3 days because we have learned that if we remove this the day after or at the same time of the procedure, if there is virtually no drainage at the end of the procedure, pretty much a good 30% of the patient will develop this late effusion. So it's something that is much more frequent than what certainly was reported in the early experience. One of the potential advantage of the epicardial approach is that we leave no device behind. Within the epicardial approach, we have a device there. Potentially, although it's certainly something that requires less skill, easier in terms of acute deployment. There are certainly a variety of issues with the endovascular approach. So the percutaneous occlusion does not require general anesthesia. Although I have to say that in our institution, when we do lariat, we use general anesthesia. But for the most part, the major advantage is that it's probably a more flexible approach and does not require transeptal and does not lead the device into the system. There are a couple of options that has been proposed. This is one of them, the Epitex, that use an access that is pretty much the same access that we use for the approach when we need to do ablation procedure, so there is nothing special about this. And this is probably a space where we need devices that are more forgiving, where the experience of the operator, as I mentioned so far, and our actually experience with epicardial access for other procedure is really not as bad as some other experienced institutions have reported. We haven't seen this 4 or 5% rate of complication, but clearly this is the result of a lot of experience. So certainly access is one space where there is need for devices that are really give more information about access. We actually have just terminated an early experience with the device to get some feedback of where we are. We've done this in Europe. We're going to present this at HRS. And this is sort of an early stage. I think we certainly need more technology in that space. But once we are in the epicardial access, this is a potential option. It's a device where there is, it's almost like a atrial clip deployed percutaneously. If you see, there is a grabber over which we advance a device that achieves the occlusion similar to the AtriCure atrial clip. What are the issues with this approach? Well, actually this device now has terminated their clinical investigation in Europe, for the most part because of this issue. Despite it looks simple to deploy, actually an optimal deployment was achieved in less than half of the patient. So that was a major issue that sort of led to the termination of the clinical investigation. And I'm not sure if they are actually looking at revamping the device or they sort of stop, and that will be the end of the story with this system. Another system which is a similar concept is a device that has been designed by the group at Mayo, which really has a similar concept. There is a grabbing system over that is used to grab the appendage, and then over this grabbing device, a lariat similar concept loop is wrap around the appendage and then close it. In animal, they have proven this actually result in electrical in sort of necrosis of the appendage that become electrically inert. Actually, this is some recording where you see not only the flow dropping down because the appendage is closed, but also when you look at electrically before and after, you see that the recording from the appendage sort of disappear. And this is a semi-acute result. And this is an example of, in an animal, of the acute and chronic closure. You see here the system, where there is a grabber device over which the loop is advanced and then the appendage is nailed. This device actually has enrolled 50 patients in the early European testing, and so far the results are promising. We have to kind of wait a little longer, obviously, to see where it's going. This is actually another closer look at this snare in both epicardially and endocardially. So I'll stop here saying the atrial fibrillation is a frequent cause of stroke. Thrombi originating the lateral appendage is in most of the patients, and catheter closure of the appendage is a feasible, relatively safe procedure. I think we're going to have soon, beyond the early study of the protective, in a couple of weeks, we're going to have more data about this, the endovascular approach. Currently, 2 devices are available in the US. You have seen the Watchman and the Lariat, but many other are currently under development to try to address some of the issues that I mentioned, both with the epicardial and the endocardial approach. Thank you very much.